Hey, it's Raph. I'm over a year on T, over a year post-op, and finally bringing you the types of top surgery video that I talked about ages and ages ago. And it's supposed to be part of my top surgery one-on-one series that I also started ages ago. I'm going to preface this video with just a few disclaimers. I'm only going to be covering top surgery options for those who are assigned female at birth, or those who are assigned male at birth. That's a different thing. You don't have to get top surgery if you don't want to. Getting top surgery or not getting top surgery doesn't make you any more or any less trans. I'm not a doctor though, I'm not a qualified expert or anything like that. So if you have any big questions, defer to your surgeon and don't rely on a stranger on the internet. The content on this video is going to be a little bit graphic, and it's not intended to be anything inappropriately graphic. It is purely for educational purposes. It's not intended to be nudity for no reason, because we are going to be talking about breast tissue, and I'm going to be showing some illustrations I made for this video. All of the graphics and illustrations and stuff that I'm going to be including in this video is stuff that I have made myself. So if you wish to use them outside of this video, please credit me in some way. I would really appreciate that. And I'm also planning to make a blog version of this that will be going on my website. I'm going to be linking down below. On to business. The first and most common kind of top surgery will be the double incision mastectomy. That's the one that I've gotten. It's often shortened to DI, or DI with nipple grafts, or DI no nips, depending on who you are talking to. But within the trans community and our circles, that's typically what we will refer to them as. It is the most common procedure out of the different kinds of top surgery that are available to us. And that's mostly because it is fairly reliable and is applicable to most any body shape and size and chest size. Often it's the only option that's available for larger bodies and or larger chests. Some surgeons use drains, some surgeons do not, depending on the surgeon and their practice and their training. The procedure starts with an incision on each side of the chest, just below the pec muscles. They take out the skin, the fat tissue, and nipples, and this is what creates the horizontal or U-shaped scars that you see on most of us. And for cases where the tissue and fat are very close together, a lot like mine was, the scars may meet in the middle, go all the way across your chest. And also for bigger people and bigger chests, the incision may also go pretty far back to the side, just past the armpit. The scars themselves, they can be straighter or they can be more curved. Part of that is dictated by patient preference. Part of it is surgeon technique and surgeon skill, and part of it is just patient anatomy. There is some wiggle room for how you can request your scars to look, but it also is kind of limited to your skin elasticity and your body type and stuff like that. Within the realm of double incision mastectomy, there's also two subtypes, and that's with nipple grafts and without nipple grafts. And if you opt for a double incision with nipple grafts, it's basically a skin transplant. Once they cut out our chests, nipples and all, they're gonna put the nipples back on. The grafts are typically resized to be smaller and have less of a protrusion, and then they're stitched back onto our torso in a new position. Surgeons use their measurements to place your nipples, and they do mark that when they're drawing on your chest before the operation. By default, they're very likely to put it in the most natural place where the nipples could go on a cis man's chest, but there's some customization options that you could opt for. You can request a specific size or place. Traditionally, male nipples will sit pretty low on the chest and closer to the sides, and traditionally female nipples will be closer to the center of each chest. After the operation, the grafts are going to be extremely fragile weeks and weeks after surgery. It's probably not till the first month or so, or even a little bit after that, till you're in the clear with them. And there is always a small chance of the grafts failing and complications happening with the grafts. Post-op sensation is pretty minimal. It took me a year or so to feel I could genuinely feel them, and it's nowhere near what it used to be before. Not everyone chooses to have nipple grafts. There are people that will go for a double incision mastectomy and opt for no nipple grafts. And those who do that could have restorative or 3D tattoos done. And depending on the surgeon, you could be cleared to do that anywhere between 3 to 6 months or maybe more, depending. Chest tattoo designs and some really cool art is also something people may opt for, and they'll have a nice blank canvas after top surgery. Keep in mind that you don't want to be tattooing directly on your scars until at least a year post-op. Some people are also just happy with having a blank chest. Preferences vary from person to person. The next type of top surgery I'll be talking about is keyhole, and it's typically only people with very small amounts of chest tissue and good skin elasticity that will be eligible for keyhole. It starts with a small incision made just under or across the lower edge of the areola, and fat and tissue is removed by liposuction through that little tiny incision. Skin will go inward to contour around the shape of your chest. There's less control over nipple placement and size. But adjustments to that can be considered as another operation that you can have like 3 to 12 months later, depending on your agreement with your surgeon. The result does have minimal scarring and has a higher chance of some retained nipple sensation. Theoretically, you can be like more like stealth with Keyhole. The next type of top surgery I'm going to talk about is Periareolar, also called Peri within the community. This procedure is typically done by people who have chests that are a bit too big for Keyhole, but still some good elasticity and a more moderate amount of chest tissue. Not all surgeons do it though, so you'll have to find out from your surgeon if they do it. The incisions are cut along the outside of the areola, and then another second incision is done around that first incision. So you get like a little radius of incision and then a bigger radius of incision, and that like donut shaped like skin and stuff is going to be removed, and all the underlying fat and tissue with it. From there, the nipple can be trimmed a little bit while still keeping the blood and nerve supply mostly intact, and then everything will be stitched together, closing it like a drawstring bag. The scars are not typically as noticeable since they're around the areola, and it does have a higher chance of preserved nipple sensation than double incision. There is a chance of the skin and stuff occurring around the incisions, and like a vertical cut just below the areola might be needed to remove the excess skin. So those are the three main types of top surgery that we'll typically see, which is double incision, Keyhole, and Peri. But there are other options as well. What I just covered and what I will cover in this miscellaneous section is not the most extensive list. There are probably other procedures as well, and this is just a list I've compiled to the best of my ability with the research that I've done. And if there's others, feel free to let me know in the comment section. But yeah, another type of top surgery which is not as common is the inverted T anchor, an option for larger chests where you can keep your nipple and areola attached to your body to avoid the need for nipple grafts. The idea is to have a higher chance of preserved nipple sensitivity and sensation. It is not a guarantee, but it does seem to help a bit. It does have a lower risk of complete nipple loss than DI does, but it may not have the level of flatness that you get with DI, and there's less precision and control with nipple placement and nipple size. It starts off with similar incisions as that of DI with cutting around the chest tissue. Additionally, a thin flap of nipple and tissue is peeled back from the chest but not fully removed. But once the excess fat and tissue and all of that is removed, the flap and nipple and stuff is put back against the chest, and then everything is like stitched closed, and the result is scars that look like an inverted T, hence the name. Another type of top surgery is the fish mouth procedure. It's less common because of how it results in a less natural look, with the incisions higher on the chest, with the areola and nipples in line with the scar. And it does seem to appeal more to non-binary than to binary people, but like to each their own. You do want to make sure that your surgeon is able to do it and offers it, so keep that in mind. Finally, the third option I'm going to go over is the chest reduction. It's another approach to top surgery that's typically more common in gender non-conforming people or non-binary people. It involves reducing the chest tissue, but unlike the other procedures I mentioned before, the goal is not to have a flat chest, just to have a small chest, or as small as possible. And there are many reasons for people who would want to go with this option, but there are two main reasons that I've seen typically. And the first one is that like a small chest but not a flat chest is what aligns most with your identity. The second reason is since some tissue is left, there is a possibility that you would still be able to produce milk if you do wish to carry a child at some point. That's a factor that some people also would like to consider. So yeah, in conclusion, different people have different needs, and I suggest you work through what you think feels right for you, but also keep in mind the limits of what your body is and what you would be eligible for. And talk to different trans people who've experienced different surgeries and gotten different results. Even the same procedure will have drastically different appearance on one body versus another body. And research your surgeon options, see what they specialize in, find out what their limitations are. Some surgeons have BMI limits, some surgeons have more restrictions when it comes to substance use and stuff like that. Be aware of that as you get ready for this big step. And the links and resources that I've listed down below are where I got all of this info. Feel free to do some of your own research as much as you can, and let me know in the comment section if there's anything I missed or if you have other questions. In my next video in this Top Surgery 101 series, I would want to like do a prepping for top surgery kind of video. So if you have questions that you want me to cover in that video, let me know, and I'll keep you all posted for when that video is ready. And I hope you all have a good day. Thanks for watching. Bye.